Hello, I'm Anthony Chan. I'm consultant rheumatologist in Reading, in the United Kingdom, and I'm reporting here from ACR 20. There have been a lot more interesting posters and abstracts today in the conference, and I wanted to share with you some of the abstracts which I thought were really interesting, especially in the field of axial spondyloarthritis. Now, as you know, the treatment in axial spondyloarthritis has expanded. We have seen new modes of action, including IL-17 and also JAK inhibitors. Today, I want to concentrate on the new data that's available in the field of axial spondyloarthritis, particularly in the mode of action, which is from IL-17 inhibition. Now, we know IL-17 can form as a homodimer or an heterodimer, so it can bind the IL-17 in terms of IL-17A and IL-17F subtypes. And in the area of IL-17A, there are two agents that we currently use in our clinical practice. And there are some up-to-date data from the conference today. Firstly, in abstract number 1366, there is a study looking at the use of secukinumab, which is an IL-17A inhibitor, and they've studied this in the non-radiographic axial spondyloarthritis group. As you know, there are two groups, the non-radiographic and also the radiographic, what we know of as ankylosing spondylitis. In the non-radiographic group from the PREVENT study, they have now looked into a bit more detail. And what they've done, they categorized the patients according to their MRI and CRP results. And what they found is that patients were either positive for both MRI and CRP01. And they found that they were, in fact, the treatment worked across all groups, but the treatment was most effective in the MRI positive and CRP positive or the double positive group. And they looked at outcome measures such as ASAS 40 and also other outcome measures such as the BASDAI 50, ASAS partial remission, and also SDAS inactive disease. In the ASAS 40 group, the double positive group achieved an ASAS 40 of 54% versus 21% in the placebo group, and very similar results in the other groups where they were single positive. So I think this is a really encouraging result, a signal that we can see in the non-radiographic group. The other agent that's being used is called izokizumab. Now, this is another IL-17A agent, and the study is called COAST-X. And in poster number 1367, they looked at the aspect of the effect of IL-17A inhibition on work. Now, work is a big issue for our patients. There's a lot of absenteeism or presenteeism, and how we can look at these two aspects of the work in patients with axial SpA. And they found that IL-17A inhibition with izokizumab improve productivity and also activity impairment and also presenteeism and reduce absenteeism with treatment. So again, it's good to see that beyond our traditional measures of efficacy, such as ASAS 40 and BASTI, there's also improvement in some of the patient-reported outcomes, such as work and productivity. So that's again a very positive signal. Now, if you look at the IL-17, there's also the subtype IL-17F, and there is a report today, a poster 1364, which looks at bimekizumab. Now, bimekizumab inhibits both IL-17A and F, so it's a combined dual inhibition of IL-17A and F. And they looked at the outcome measures, and the study is called Be Agile. And what they had done is they looked at the extension study beyond 48 weeks. So in the first part of the study, they had patients going up to 48 weeks. And what we saw in the first 48 weeks, there was a rapid response. Within 12 weeks, patients had already starting to respond to the treatment. 87 of these percent of the patients carried on beyond 48 weeks, and they went on to 96 weeks. And when we looked at the non-responder imputation results of the ASAS 40, 65% of patients maintain ASAS 40 at week 96. The ASAS partial remission was 36%, and the SDAS inactive disease was 28%. So this again shows the benefit of IL-17A and F inhibition All these studies tell us that the mode of action of IL-17 inhibition is again increasing our choice of treatment and also the mode of action beyond the other treatments. This is really an encouraging sign for us as we see of our patients, and they vary and they have different clinical features, and it's important for us to have choice when we make some of the treatment decisions that we have in our clinic. I'm Antoni Chan, reporting from ACR 20. Thank you.